Hi everyone. I hope everyone can hear me in the session. It's just gone past 11. My name is Taz, and I'll be hosting the plastics session here. If you can't hear me, just mention on the just comment on the comment section. I'd like to welcome you to the plastics session and also to the Assess conference. For those who joined for the morning session, I hope you found it interesting. For the time being, what we're going to do is we're going to be doing we have 8 sort of papers for the plastics specific sessions, and we have a presentation from the Association of Breast Surgery as well. Before we go on to the Association of Breast Surgery's talks and presentations, I'm just going to bring on Miss Roba Kunkar, who's going to be the judge for the presentations today in the plastics section. Hope that's going to work. Robert, do you want to just ask for access again, please? Oh, perfect. Things worked.
Hi.
Hi, Robert. Do you want to just introduce yourself, if that's okay?
My name's Shoba Kunta. I'm a consultant plastic reconstruction and sarcoma surgeon at North Bristol NHS Trust in Southmead Hospital. I also have an academic role at Oxford University as a senior clinical lecturer in global surgery. Taz, thank you very much for asking me to assess. I'm sure some very excellent presentations coming up.
Perfect. Thank you so much. So I'll bring on to the Association of Breast Surgery. I would really like to thank them for their support for this conference. They've kindly sponsored our top 3 prizes today, which are going to for the winners today. So I will bring on Diana Kazazi. I hope that works.
Hi.
Perfect.
Hello.
Hi, Diana.
Hi, I'm one of the plastic registrars at St Thomas in London. So I'm the junior rep for the mammary fold, which is a sub kind of section of the Association of Breast Surgery. And I'm just going to start sharing my screen, if that's okay.
Yeah. Once it works, I'll take everyone off.
Okay. Can you see this?
You can see it. Yeah.
Is that okay?
Yeah. So I'll take off. Yeah. Perfect.
So just going to talk briefly about breast surgery, because that's what we're about. And I'm Diana, so I'm the junior rep, and we've also got Hood, who's the social media rep with us. Because I'm more of the plastic side of things, Hood is a general surgical trainee, so we can field questions from either side if you want to ask anything. I just thought I'd start by saying why I think you should pick breast surgery. So firstly, you have surgical and non-surgical treatment of all sorts of breast disease. There's a wide spectrum. So there's kind of oncoplastic and reconstruction, there's benign, congenital and cosmetic. And you could get involved in anything, and it just depends what your interest is. So there's a lot of scope for academic work, and obviously you're all interested in that because you're here, which is really good on a Sunday. There is an MDT approach to patients, and your colleagues are so passionate about their jobs, and it's really inspiring to work with such people. And also it's just such a because you get such a personal relationship with each patient, and you just know that you're making such a big difference to their life, and it's just a really great job. So how can you get into breast surgery training? There are 2 ways. You either go the general surgical route or the plastics route. And obviously I'm talking to the plastics room, so I know kind of where you already want to be. But just to talk quickly about the difference between the 2, if you go the general surgical route, so you obviously do your foundation and your core training, you apply for general surgery. It's ST3 to ST8, and if you declare your interest in breast surgery early, you then have your ST7 and 8 that become purely dedicated to breast surgery, and you are not on the on-call rota for those 2 years, and you get your full complement of kind of breast training, and then at the end of it you get your CCT and you are end consultant oncoplastic breast surgeon. In plastic surgery, it's slightly different. So again, you do ST3 to ST8, and again, declare your interests, and depending on your kind of deanery and the way that you can tailor your placements, you could ask to be on the breast firms. But often people will go on to do a fellowship, so at least a year out before they go on to take up a consultant post, and that just means that you have a dedicated year to practice. The difference between general and the general surgical training and the plastics training, the general surgical training tends to be more kind of the treatment of the cancer. So if you're being involved with the chemo, radiotherapy, hormone therapy, and then you would do the treatment of the cancer itself, so the lumpectomy, mastectomy, etc. And then the plastics team are involved more in the reconstruction of the defect. So, for example, if you've got a patient who's had a mastectomy, they may need a free flap, so a lot of microsurgical things, and it just depends where your interest lies, whether it's in the treatment of the cancer or the reconstruction. Obviously, there's a mix of both in each, but there is more of a theme depending on which way you want to go. So about the Mammary Fold, we are a national association. We're run by trainees for trainees, and we're kind of part of the Association of Breast Surgery. And we are for anyone who is interested in breast surgery, whether you're plastics or general surgical. We want to educate members about breast surgery and breast disease, represent trainees on other appropriate bodies. For example, we always have a presence at conferences such as this one today in ASIT. We want to encourage people to pick breast surgery because we think it's the best. And also for current trainees, we do support current trainees by having regional reps. So if you've got any concerns or problems or questions, you can come to that person for careers advice or to voice your concerns and see if we can do anything to help. And we also provide a lot of educational resources. So we have webinars. Recently, we've had one about the breast MDT that had multiple kind of consultants giving us a talk on the different aspects of breast management. And that included breast surgeons and oncologists and histopathologists. So that was really interesting. We've also had a talk recently about how best to CCT. So again, supporting you as a trainee, even towards the end of your training. Prior to COVID, we hosted conferences and social events where you could network and meet other people. As I said, we've got the regional reps. We've also got an academic and research collaborative, if that's your interest. And again, we just provide a lot of support and careers advice if you need it. If you've got any questions about breast surgery training, you can get in touch. So if you want to become a member, you can go to our website. You need to have membership of the Association of Breast Surgery first. So you just need to find a couple of people who are already members, and that's really easy to do. And if not, you can just email us and we will support your application. And then you apply for being a member of the Mammary Fold, which is free to core trainees. And then once you hit ST3, it's £50 a year, but it's a very good investment for what you get in return. And if you need any more info, just email us or find us on our Twitter. It's the Mammary Fold 1, and that's where you'll find lots of updates on upcoming webinars. And if you need to ask any questions or any advice, there's also a lot of information on the Association of Breast Surgery website and on BATpress. And if you need to, then you can email me too. And that's it.
Perfect. Thank you so much. I didn't see any questions in the site. Shall I get Hood on as well? I think I've seen a request from Hood. I think from my point of view, thank you so much for coming in and firstly sponsoring and also sort of educating us as well in terms of what you guys offer. Can I ask from a core surgical trainee as well? I'm not very aware of the kind of services and how sort of breast surgery works. So can you give me a sort of outline about that, especially in the UK?
So do you mean like what breast surgeons do?
Yeah. So how does that actually work in between sort of the general surgeons and the plastics, and what's the divide there?
Okay. I will let Hood talk to you about the general surgical job plan, and then I'll take over.
Yeah, okay. Can you hear me okay?
Yeah.
Yeah. So in terms of when you become a consultant, then there's hardly any centers left where breast surgeons do any general surgical on call. So it's 90% of the work is just breast surgery, seeing new patients, planning treatment in terms of oncological in partnership with oncologists, radiologists, pathologists, operating on new cancers, and then planning sort of reconstructive procedures and anything else that requires microvascular techniques or advanced reconstructive techniques. We collaborate and work with the plastic surgeons. So in terms of the general surgical route, oncoplastic breast surgeons, they need to be aware of both plastics and general surgery, so they know what the best techniques that are suitable for the patient, so they can refer appropriately. So we work closely with plastic surgeons. In terms of your training, you have to do general surgery, so that's colorectal, upper GI, some vascular, during your training. But the last few years, I just focus on breast surgery. Hope that answers that question.
Yeah, perfect.
And then just to follow on from that, if you go the plastic surgical route, then obviously you're doing your general plastic surgery training as well. So that's all those subspecialties that are related to that. And specifically for breast, so for each subspecialty, you have your indicative numbers. So you need to have a certain number of procedures for each subspecialty that you've at least assisted in or performed. So that includes breast surgery. So you do, again, like Hood said, you need to have an appreciation for the full patient journey and all the different treatment options for each different types of cancers, etc. You're not just there to reconstruct. And then when you become a consultant, then you kind of are more the reconstructive side. So that usually involves microsurgery, free flaps and reconstruction that way. And I think another important difference to note is that usually when you're the plastic breast surgeon, you are still on the on-call rota, whereas I think for general surgery as a breast surgeon, you don't tend to be on the on-call rota, unless that changes in the near future. There's been a bit of talk around that.
You'll be on the on-call rota just for breast procedures, but it's not very busy. Whereas I'm assuming for plastics, you might be on the trauma on-call rota,
yes,
which is more demanding.
Yeah.
Perfect. If there isn't any other questions, I will post a link for the ABS and Mammary Fold on the chat, and hopefully people can take a look during the time. Thank you both for the talk.
Thanks very much.
Thank you.
Perfect. So the first talk today is by Albie Keeley. I will let you in.
Success, can you hear me?
Oh, success, yeah. Do you want to share your screen?
Application window, share.
Perfect.
Okay, forgive me if my internet is not 100%, but good morning, everyone, and thank you very much to the Virtual Access team for hosting me. My name is Alva Kiley, and I'm a current CT2 plastics trainee at the Queen Elizabeth Hospital, Birmingham. My talk this morning is based on a 10-year review of 313 pediatric hand fractures, looking at functional outcomes in particular. So pediatric hand fractures are common. They make up 2% of emergency presentations in children and 15% of all pediatric fractures. In practical terms, the most important outcome following the management of hand trauma is how well patients can use the injured hand following treatment. However, function is not an outcome that has been well explored in children. The aim of this study was to assess range of motion post, manipulation and splint, percutaneous K-wire fixation, and open reduction internal fixation across 10 years of phalangeal and metacarpal fractures in children. So patients were grouped by location of fracture and type of management and compared using chi-squared or Fisher-exact statistics for the primary outcome of the range of motion achieved at maximum follow-up. Total active motion, or TAM scores, were calculated as described by the American Society of the Hand, where the injured digit is compared as a percentage of the baseline range of motion on the contralateral hand, so middle finger matched to middle finger, for example. A good outcome equated to 75% of the range of the opposite digit. Secondary analysis of outcomes for different classifications, eponymous fractures, and a comparison of function versus fracture reduction were carried out in addition. So with regard to epidemiology, most fractures, unsurprisingly, occurred in males as a result of a fall or sporting injury. And by far the most common fracture overall was the little finger proximal phalanx, making up 91 of the total 313 fractures. And in a similar way to adults, the most common metacarpal fracture was the fifth, or boxer's fracture. So the proportion of patients who achieved a TAM score of more than 75% of the opposite hand in each treatment group were compared with a chi-squared test. So among 175 proximal phalanx fractures, those treated with MUA had excellent functional outcomes, which was statistically significant compared to those with metalwork. In the middle phalanx, all of the outcomes were actually really good when there was no difference between treatment groups. And fractures in the distal phalanx did worse functionally than proximal or middle phalanx, which was statistically significant. And there was no difference in fixation methods. Interestingly, of these, the eponymous Seymour fractures had particularly few patients who achieved a TAM above 75%. And outcomes in the thumb also did significantly worse than those in the other fingers. So only 16% of these patients achieved TAM above 75%. So amongst 48 metacarpal fractures, there was no significant difference across managements. And these fractures also did significantly worse in the thumb or first metacarpal, with only 25% achieving TAM above 75% versus 94% in the corresponding metacarpals. So as a secondary outcome, the post-reduction angulation for all fractures that had a good, fair outcome were plotted on a scatter plot. And you can see here that several fractures had a post-reduction angulation in either AP or lateral planes of up to 50 degrees. And they still managed to achieve a good TAM score. And this was supported by Kruskal-Wallis testing, which showed no statistical association between anatomical reduction in any plane and a TAM score of more than 75%. So we did a univariable regression to determine if certain factors made children more likely to have a functional outcome, a poor functional outcome, which was defined as a TAM score of less than 50% of the opposite digit. So while a large proportion of these patients, these 59 patients, were Salter-Harris classification, only fractures occurring in the thumb reached statistical significance for an association with a poor outcome. So overall, across all fractures, this cohort had excellent clinical outcomes, with almost 80% achieving a TAM score above 75%. So I think this study highlights that there are certain groups who did not achieve a good range of motion, namely proximal phalanx fractures with metalwork, distal phalanx fractures in general, and fractures in the thumb in general. I think of particular interest and of relevance to the known capacity of a child to efficiently remodel angular deformity, there was no relationship between a perfectly approximated fracture and a good clinical outcome. The biggest limitation of this study is selection bias for the treatment groups, which could not be adjusted for in study design. So that is to say that the more complex or angulated fractures are both more likely to need metalwork and also more likely to have poor function postoperatively. So with this in mind, it is outside of the scope of this study to make recommendations based on treatment modality. However, on the basis of this study, we can recommend that clinicians and therapists pay close attention and follow-up to these named fracture groups in the hope of maximizing their range of motion at follow-up. And I think I, for one, will consider this study when I'm approaching children's hand fractures in the future, in not becoming obsessed with fracture reduction and focusing on what the clinical outcome should be. So these are my references, and thank you all for listening today. I'd like to particularly thank the Virtual Access team for hosting this great event, and the team at the Royal Free Hospital for providing me with their extensive trauma database. And I'm happy to take any questions.
Perfect. Thank you so much for that, for the lovely presentation. I think Robo will request to come in again to ask a question. In the meantime, in terms of, I have a question in terms of your outcomes as well. And I'm not an expert in the sort of pediatric plastics area, but are there other sort of outcomes, for example, patient-reported outcome measures that you can use instead of or in addition to sort of motion calculations with TAM scores?
Absolutely. I think, can you hear me? Sorry.
Yeah, we can, yeah.
Okay, lovely. So probably the most popular patient-reported outcome used in hand fractures or in hand in general is the quick dash score, which is really useful. I think with children specifically, this can be slightly more difficult. So that's why I chose to do an objective outcome measure. Now, there are other functional outcome scores that you can use, but a TAM score is just a really useful way of calculating function because all of these patients have hand therapy follow-up, and all of them will have a baseline reference range of motion and a range of motion recorded at the end of their follow-up. So in having all that information, it's just very easy to calculate what exactly their progress was and how they did. But I think there is a huge role for patient-reported outcome measures. It just sometimes is not as practical for children.
Perfect.
Right.
Robert.
Albert, very good presentation. I really loved your charts. They were really nicely done. So well done. Very good. I had a few questions. One was, I think, partly answered by what Taz has just asked you. I just want to know, you may have said this, and apologies if I missed it. What was the range of kind of mean follow-up for your patients? Because obviously some would have been longer or some would have been shorter. Do you know what the follow-up period was?
Yeah, it was about 7 weeks with, I think, a standard deviation of 4.
Okay, all right. And the other thing is, in your study, did younger children do better than older? Because I wasn't sure if you'd grouped all of them together for your outcomes. Presumably that's what happened because you did groups.
So that was one of my hypotheses, but interestingly, there was no difference in outcome. I was expecting that younger would do better because their capacity to remodel is more. But in fact, the data didn't really show that. Okay,
and did you actually subgroup them to have a look at that separately? What age categories did you?
Yeah, I did. I think I did 0 to 5 years, 5 years to 12 years, and then 12 to 18 years.
Okay. And one final question. This is obviously looking at patients who've had operative treatment. And in my experience, having been to multiple units, worked in multiple units and working multiple hand surgeons, even with very, very angulated injuries, some surgeons prefer to do completely non-operative treatment. And I know your study didn't look at that at all. Did you look at the literature to see how operative treatment compares to non-operative? Because if you're making recommendations, you can only make it on what you've studied, but what does that do in terms of the general kind of whole group of treatments, and non-operative being one of those treatments? Did you have a look at that in terms of where your study fits?
I did. So I had a look at some of the kind of eponymous ones that did quite badly, and it definitely can be the case that, so if there's obviously an open element, that's different. But I would suggest that probably non-operative treatment is preferred. So for Seymour fractures, for example, it's usually they're a particular one that do need operative intervention because it's open essentially. But it seems the general trend across several fractures, named and otherwise, is to try and prevent manipulation. I think with Salter-Harris fractures in general, you sort of only get one shot at manipulation, and usually if you get a slightly better reduction, it means that the healing is usually slightly improved, and you're obviously concerned about the growth potential of a child. So with that particular subgroup, I think there is more of a trend to, yes, take them to theatre, even if their angulation is minor, because you don't want to risk doing something in ED under Entonox or whatever, it not being perfect, and you're losing the golden opportunity of reduction. But I think the
sorry.
I think the
studies that look at that, you know, whether doing the operative versus non-operative in Salteld-Harris closed fracture, that's all. So whether you found anything like that that would give you evidence rather than the trend.
Not specifically. I didn't find anything like that.
Thank you. Excellent presentation.
Thank you so much. So I will take you off the screen. Next up, we have Grant Nolan. I will add you to the call. Hopefully it works.
Hi, can you hear me okay?
Hi, Grant. Yeah, I can hear you perfectly. Do you want to share your screen as well?
Yes. Can you see those slides okay?
I can. Perfect.
Great, thank you. Just ask people to double click on the slides so that they appear large to you. My name is Grant Nolan and I'm a course surgical trainee in the Northwest. This morning, I'd like to present our collaborative study, The Effect of the COVID-19 Pandemic on Skin Cancer Surgery in the UK, a national multi-centre prospective cohort study and survey of plastic surgeons. Non-melanoma skin cancer is the commonest cancer worldwide and accounts for 20% of all new malignancies in the UK. It includes basal cell carcinoma and squamous cell carcinoma as the commonest subtypes. The mainstay of treatment is surgical excision, and the majority of complex and high-risk skin cancers are excised by plastic surgeons. Treatment success is directly related to achieving clear margins. Based on previous national audits by UK dermatologists, we designed a national audit on skin cancer excisions by plastic surgeons. This commenced on the 16th of March 2020. Shortly after, the COVID-19 pandemic caused widespread disruption to healthcare services, and a lockdown was declared on the 23rd of March. It was swiftly adapted with the aim of determining the effect of the pandemic on skin cancer surgery in the UK. A national multi-centre cohort study was performed. Prospective data was collected on non-melanoma skin cancer and retrospective data on melanoma. This collaborative project was coordinated by the Reconstructive Surgery Trials Network and supported by our specialty association, BAPRAS. Trends in patient data were confirmed with surveys of plastic surgeons who specialise in skin cancer. The primary outcome was surgical provision by tumour type. Data collection began on the 16th of March and ran until the 14th of June when lockdown was eased. Data from the first week was used as a control as normal NHS duties were undertaken at this time point. Overall, 32 out of the 50 plastic surgery units in the UK submitted patient data, with a further 2 units contributing survey data. Over the 3-month period, 2,088 patients were submitted into the study. 2,050 patients were included in the final analysis. The mean age of patients was 70 years and 60% were male. As can be seen by the box plot, compared to pre-COVID levels on the left here, there was a large reduction in the number of skin cancer operating lists for general anaesthetic lists in blue and local anaesthetic lists in red. General anaesthetic cases were affected more. These findings were statistically significant at the 5% level. When lists did go ahead, between a third and half of these were in private hospitals. Surgeons moved to using absorbable skin sutures, increasing from 53% to 86% in June. The number of non-melanoma skin cancers treated per week fell dramatically by up to 47% at the onset of lockdown. This reduction was due to reducing basal cell carcinoma excisions, as shown by the falling blue line. In April, 73% of surgeons reported they had stopped excising BCCs altogether. SCC excisions were prioritised, as shown by the red line. SCCs became the majority of non-melanoma skin cancer excisions, and between the 30th of March and the 5th of April, 71% of preclinical diagnoses were SCC. This coincides with the peak number of COVID-19 hospital admissions and deaths. The normal proportion of SCC excisions is just 28%. Radiotherapy and Mohs micrographic surgery, which are reserved for the highest risk tumours, were severely affected. Surgeons reported 70 to 77% of these services were reduced. Like squamous cell carcinoma, melanoma treatment was prioritised, yet affected. Only 26% of patients with a Breslow thickness greater than 0.8 millimetres underwent sentinel lymph node biopsies during lockdown, which contradicts international guidelines. 60% of surgeons stopped performing sentinel lymph node biopsies altogether in April. Lymph node biopsy is to upstage a proportion of melanomas by identifying distant spread. These patients then become eligible for immunotherapy. Most of these patients have therefore missed out on being offered immunotherapy, and the consequence of this is unknown. Immunotherapy was severely reduced. Only 8% of surgeons reported normal service was running in May. Surveillance stopped in 10% of units. In terms of complications, 2 patients, which is less than 1%, developed COVID-19 within 2 weeks of melanoma surgery, and of those, one of them sadly died from COVID. Other complications were rare, and 93% of patients had an uncomplicated course. Clear excision margins were obtained in 94%. Around 90% of surgeons followed up their patients via telephone, an increase from 12% pre-lockdown. Our study demonstrates that all skin cancer treatment was negatively affected by the COVID-19. High risk and complex lesions were worst affected. Novel adaptations were implemented at speed. These reduced face-to-face interactions and utilised alternative resources like private hospitals. This study demonstrates that the surgery that did continue during the pandemic was safe, and the spread of COVID was not directly linked with skin cancer surgery. This is a key finding in the light of a potential second upcoming wave. 92% of surgery was performed under local anaesthetic. Complication rates were low. Previous literature on the high mortality of continued operating during the pandemic appears less applicable to this patient group, and the risks of COVID-19 must be weighed up against the increased morbidity and mortality of delaying treatment. As lockdown is reduced, skin cancer services should be resumed urgently, as the risk of untreated skin cancer may now be considered greater than COVID-19. Finally, I'd just like to say a special thank you to all the collaborative authors listed below who delivered this project. Thank you very much for listening and for organising. I would love to answer any questions you may have.
Perfect. Thank you so much, Grant. Robert, do you want to go first?
Do you have any questions?
I had a few questions. One of the questions was actually for the wider public in terms of if you can talk them through the RS, because I think it's a great opportunity for all plastics orientated trainees and what they specifically offered for you during this. And the second, well, yeah, you can answer that and I'll get on to the second question.
The RSTN is a collaborative network. I'd never worked with them before, and filled in a form online with this idea, sent it in, and then it all snowballed from there. So they took it right from this beginning idea, provided methodology support, and then helped disseminate the survey. And fantastic response from such a wide range of people all over the country. So it was a really positive experience. You know, it's obviously a lot of hard work, but I think the outcome from it has been really brilliant. So yeah, it's a great thing. Perfect.
Yeah, I have no vested interest in our RSTN, but I've seen some great stuff. So so perfect. Thank you. The second question was, I know your conclusions basically concluded that there was actually positive outcomes in terms of skin cancer specifically compared to other types of cancers. How do you think the referral patterns from primary care, as well as sort of the cultural consequences of the pandemic on individuals actually seeking help and seeking medical advice, will affect our skin cancer services in the future?
Yeah, so we did try and look at exactly what effect the pandemic was having on referral patterns, trying to tease out the data on when the referral was made, when these patients were seen. But we didn't notice any big delays, actually. I think GPs have been very good at bringing on board lots of e-medicine, taking photos of lesions. This pandemic's really shown that we can actually do a lot of surgical planning from just a photograph, and that carers and patients are very capable of taking clinically relevant and useful photos and sending these in to us that we can use to plan the treatment. So yes, I think it has had a huge impact on lots of things, but there's obviously some positives that we can tease out and take these forward in our careers.
Right. Well done, Grant. That was a really excellent presentation. Again, the quality of these presentations are really, really good, and you've clearly put in a lot of work into it. I'm going to ask you something about the methodology. In my experience, doing collaborative work is really quite hard. How did you manage to get engagement from so many units, and what did you do? Why do you think the ones that didn't respond, why didn't they respond?
So for engagement, it was sort of twofold. Firstly was the RSCN have a network and sent out emails. Then we also went through BACPRAS, who were very, very supportive, and they also contacted consultants through their newsletter. So it was kind of a bottom up from trainees and then a top down from consultants as well. And that created this wide network of people who were interested. I think when people hit, it's an easy project to get involved in. 30 patients with skin cancer, they come through the department all the time. That's maybe 3 or 4 lists. So it was, a lot of time in lockdown was frustrating for all of us. This was an easy project to crack on and get done and get involved. So I think it kind of hit at a good time from that point of view as well.
Okay. And like I said, there were 34 that responded. There's still quite a large number who didn't.
Yeah.
Why do you think they didn't? Because it's always a recurrent problem when we're trying to gather data. How much of the real data is actually in the teams that didn't respond? Maybe they were too busy to actually do the survey, for example.
Yeah.
And it's always the question is, well, the data do you have? Are you absolutely confident that that is representative of what's happening? So why do you think they didn't engage?
I think part of it is that, although some of us had time, obviously a lot of people were very busy. And I think unless you have a team who have this opportunity and have the time and the support to do it, it's not easy to register something and get it all sorted. So I think part of it is access to the support.
Okay.
Knowing about the project, but it is certainly a challenge trying to get these units involved. I think next year going forward, when we sort of try and make this happen annually, I think we will certainly target these units and try and get them involved and work again with trainees and with consultants to get as much involvement as possible.
Okay. I guess my main question is really, are you confident that the data you have is representative of what's happening in skin cancer and plastic surgery? Or do you think amongst the ones that have, did you look at the units themselves to be sure that you haven't missed out any major skin cancer units?
Yes. So I think there's always going to be a question about that. And one of the big limitations of this study is that it wasn't designed to track a pandemic. Yeah. It was designed to be a national audit of skin cancer, and then we've just adapted it. So I think that's a huge limitation, and we have to bear that in mind with any sort of conclusions that we're drawing. The strength of it, I think, is that we had the surveys which showed the same patterns. I think if we just had one, the drop in numbers, is that because doctors have been redeployed? Is that for other reasons? What's going on? But the fact that it was backed up with this robust survey data, which again is quite weak on its own, but then combined with the patient data helps build a cohesive story. So I am confident in the findings, but only because of the both elements.
Okay, and just to clarify, part of it, your study was the survey, and the other one was data was collected from what route? I know consultants and trainees did it. What was the actual process of collecting the data?
So that was using a program called RedCap, which is like an online survey, which you submit so that collaborators submitted anonymized data.
Okay, so from RedCap. And in terms of the outcomes that you collected, obviously you presented the main outcomes, which is excellent, and they seem, kind of follows kind of trends we've been expecting. Were there any outcomes you collected that you didn't present because you didn't expect them to be there, or are these all the ones that you collected and you presented all your data?
It's a phenomenally large database that we've collected. It's been really rich. So, it looked at everything from patient demographics to pre-operative, operative details, histology, and then clinical follow-up. So this is just a flavour, really. I've just tried to cram in as much data as possible.
Yeah.
But things like reconstructions, we looked at, did that change? Were surgeons taking a different approach? There were pandemic guidelines produced which said we should be trying to do more flaps to reduce follow-up from graft failure.
Yeah.
We didn't really see that. We didn't really see a change in lesion size. We didn't really see a change in, we thought maybe more advanced lesions would be seen, or larger lesions, more aggressive lesions. None of that really happened. So I probably have only presented the positive findings rather than going through all the negatives. But a lot of it played on as normal, actually.
Okay.
Reconstructions and such.
Yeah, because to some extent, all the results matter. The negatives are actually as important as the positives. To say what is also continuing to happen and no change. Okay, and a final question, which is more of a kind of overall question. If you look at a flow of kind of when you do research, you kind of have an input, which was your input is, collecting all this data, telling people, we're going to do this survey. And your output has been learning that there's been surgical services which have been reduced. And that's really what you presented, the output. This is what's happening. This is what used to happen. This is what's happening now. The outcome is essentially the impact on patients in terms of their cancer overall as a population. How do you think you would actually assess the impact? We know that it's reduced level of services, but we actually don't know what's happened to the patients as a result of that.
Yeah. And I think that's a huge issue that we just need to, and it's not an easy question to answer, especially when
it may be that it's had no impact. Maybe it doesn't make a difference whether we take out all those VCCs or not. So how would you go about designing a study that would look at actual impact, and that would be the ultimate outcome of the study rather than just an output?
So once some sort of patient-reported outcome measure, looking at how pleased they were with their procedure or with their service. Phase Q, which has a skin cancer module which can be used. I think we should add in sort of things like cost and inconvenience of patients. We've moved everything online, so telephone consults have moved. I've got rid of a lot of face-to-face interactions. Now, whether this will stay and whether there's some colloquial evidence, certainly in some of the white space answers, where patients seem to enjoy a phone call with a consultant maybe more than a follow-up with a registrar they hadn't met before. So there's lots to tease out, and I think maybe a qualitative study combined with the PROM would help get to the bottom of this, but it's going to be hard to answer, but something really, really interesting and fascinating to know.
Thank you. Well done.
Thank you.
Perfect. Thank you, Grant. The next presentation is by Catherine Wensley. Catherine, can you? Oh, perfect. You've already think. And this will actually lead very well on from Grant's finding of increased use of absorbable sutures as well. So, perfect.
Hello, can you hear me?
We can hear you.
Can I try and share my screen? Oh.
Perfect.
Hopefully you're able to see that, sorry. Oh.
We can see it.
Are you able to see that maximized?
Not at the moment. I can't see it. Can you see it maximized, Robert?
Yep.
Yeah. Okay.
Sorry, is that maximized?
No, it's not actually. It's in the middle. We need to play, I think.
So I'm playing on my screen, but
what you can do instead, if you would like, just zoom in if it's not working. I guess from the bottom right corner, that should work as well.
Sorry, I will just go to the start then.
I can see that. quite
Okay,
clearly.
I'm sorry about the technical difficulties.
No.
I'm just wondering, actually, if I'm going to be able to move the slides forwards.
You should be able to press either down or up. Would that not work?
No.
No. Do you wanna try opening up leaving the call, opening up the presentation in presenter mode, and then requesting to call and then sharing your screen.
All right.
Okay. Because there is an error that's happened on our test drives trials as well. So give that a go.
Maybe while we're waiting, there's a comment from our first presenter on the second talk by Grant, which is a fairly good point, saying there could be units who stopped doing skin cancer at all during the pandemic. And, and that was the question we were discussing with any research project. When you don't have participation from certain partners, how do you know your data is absolutely accurate? Do you know whether it represents all your data, or whether the ones that didn't respond for a good reason? And we don't know if the other units all stopped doing cancer care altogether, which would change the findings altogether. All right, Catherine, you're back.
I'm still struggling, I'm afraid.
Try to share your screen again at this point. Make sure you maximize your presentation and then play your presentation and then share it.
No, I'm afraid I can't get it to work at all. I'll just pop out of the call and see if I can come back in.
Should we move on to someone else and then she can come back and join?
We can do. Is Lauren Bolton? Are you here? Yeah, perfect. I'll add Lauren for the time being.
Yeah.
Hi, Lauren. Hey, do you want to give it a go, see if it works?
Oh, sorry, just give me. I think it's the privacy settings. I might just have to close and reopen Chrome. Sorry.
No problem. Yeah, I think depending on what you're using, if it's a Mac, you need to change your privacy settings. There was instructions on the emails we sent as well. So if you get stuck, they're on there. Catherine, if you're ready as well, we can always give it a go if you want to try to attempt again.
So I'll try and attempt again. I think this may have been the problem.
Yeah, perfect.
Fantastic.
Great.
Hopefully I'll be able to click through. So my name is Kate Wensley, and I am a core surgical trainee in the West Midlands at the moment. And today I am presenting a systematic review on the use of absorbable versus non-absorbable sutures in hand trauma. As a disclaimer, I'm sorry, I did work overnight last night. So if I'm not quite as sharp as usual, please forgive me. But I suppose that is the beauty of a virtual conference. So thank you very much to everyone who has organised this. So I'm going to try and convince you that hand trauma is actually really important and worthy of your Sunday morning if you didn't already think it was. Firstly, that is because it's very common, and secondly, because it's also something that's really expensive. So traumatic hand injuries account for 20%, so 1 in 5 of all accident and emergency visits in England. These injuries commonly require sutures for skin closure, but unfortunately no consensus exists on whether the ideal suture to do this is absorbable or non-absorbable. I'm sure that you've all come across lots of people who have a preference, but the real question is whether they have any evidence for that preference. So of these people who attend A&E with traumatic hand injuries, it's a very high proportion. 1 in 4 of these patients actually undergo some kind of procedure and are therefore likely to have some form of sutures used, although that's obviously not 100%, but is quite likely. And the second reason that I spoke about was that it's really quite expensive. So if you're not won over by the fact that hand trauma is really common, there's a lot of money in it. Hand injuries have the largest economic impact of all injury types. And if we were to use absorbable sutures in all patients attending A&E with hand trauma who go on to have a procedure, and as a result of this, just take saving them attending a single follow-up visit with a GP practice nurse, this alone would result in savings in excess of £1.8 million a year for the NHS. So moving on to methods now. This is the study's PRISMA diagram. So it's a Prospero registered study. Between 2 authors, we identified 1,744 records through our database searching. Once duplicates removed, this was obviously slightly lower. All but 23 of these studies were excluded for the reasons listed. You'll notice that unfortunately we were unable to use not trauma as an exclusion criteria, because unfortunately when we did that, there were no studies that were eligible to be included. So this does include studies that include elective hand surgery. So there were 4 trials in progress that were listed. Unfortunately, we didn't receive any responses when we contacted the teams. So this left 13 studies for discussion. So moving on to the results, there were 10 randomized control trials, 2 prospective studies and 1 retrospective study. The risk of bias was assessed, as you can hopefully see in the table here, using the Cochrane risk of bias tool. The latter 2 clearly are intrinsically high risk of bias, just due to the study design, if nothing else. But as you can see from the table, there is generally quite a high level of risk of bias here. There are 2 notable high-risk areas of bias. That is one of the papers, the one by Ford et al., which was actually sponsored by the suture manufacturer in question. And there were also 3 studies which lacked assessor blinding. So all of the studies had at least 2 points, time points of assessment, the mean being 2.5. And then follow-up ranged from 2 days to 6 months, with the average time to first follow-up of 12 days mean and 66 days at final assessment. So all of the studies included infection as one of their outcome domains, and although they wouldn't necessarily specifically specify infection, some of them use surrogate markers. So for example, the prescription of antibiotics as what they deem to be a marker of infection or suspected infection. 11 of the 13 studies reported on pain, 7 of 13 on cosmesis, and 6 out of 13 on dehiscence of the wound. 3 studies reported significant difference in only one of these domains, 2 in pain and 1 in risk of dehiscence. In all of these, absorbable sutures were deemed to be superior. So 2 studies reported, as I said, that patients experienced less pain with absorbable sutures in both the immediate post-operative period, but also perhaps, as you would expect, when the sutures were either removed in the case of non-absorbable sutures or left to dissolve in the case of absorbable sutures. One study, that by Shetty, reported a significantly higher rate of dehiscence at day 10 post-operatively when using non-absorbable sutures. And they found that the dehiscence was such that these patients actually required additional steri-strip closure. So the overwhelming finding of this review was really the void of literature in what is really quite an important topic. And also that what does exist really is quite poor quality and often at significant risk of bias. Although the current literature can support the use of absorbable sutures, it doesn't necessarily support their use over those of non-absorbable sutures. But actually finding an answer to this question has become increasingly relevant with COVID-19, perhaps sort of set up by Grant and Alva speaking before, and how important it is to reduce the follow-up visits of patients in a healthcare setting. So I felt that all of this really just enforced the need for sort of a robust multi-centre trials and a good health economic analysis, something which I actually felt would perhaps be suitable for further review by a trainee collaborative group. And that's why it's such a nice opportunity to get to present it somewhere like here. So thank you very much, and I'll take any questions.
Perfect. Thank you so much for that. That was a really good talk. I have a couple of questions as well, if that's okay. I'm very sorry if I missed this, but what were you specifically looking at in terms of outcomes? What were the primary and secondary outcomes that you specifically searched for, and how did you go about doing that?
So we specifically looked at pain, cosmesis, and wound dehiscence, as well as infection. Infection was our primary outcome, and the other three were secondary.
Fine, perfect. And the second point is, was there any opportunity for you to perform a meta-analysis with the data that you had, or was it such that it was so varied that you couldn't?
That was initially our aim. Would have been to perform a meta-analysis, but actually the data quality was so poor that it wasn't appropriate to do a meta-analysis. I guess, you know, if there were more higher quality studies, that might be plausible, but at the minute it would be meaningless.
Perfect.
Thank you. I think thanks very much. Well done for coming and doing this after your night shift. So get extra points for that, I think. So well done. I do have a few questions, and again, I was going to ask you the question that Taz has asked about the outcomes, but you've already answered that. My first question would be, what was your actual research question? And again, apologies if I've missed it.
So our question was really whether it was appropriate to use non-absorbable sutures in traumatic hand injuries.
Okay, so that's the question.
Yeah.
And what's the rationale for that? Why did you choose that question?
So we wanted to know that to try and reduce the burden on our follow-up services in the hospital, patients attending for dressing clinic. Our patients didn't actually attend their GP, they attended for dressing clinic, although I appreciate that a lot of other trusts' GPs would follow that up. And we found that there was just a very high burden, both adults and paediatrics, on our dressings clinic nurses, providing not even just one, but sometimes up to 5 follow-up appointments.
Okay, so so this is really looking at kind of a finance point of view for absorbable versus non-absorbable. And remind me what your outcomes were.
My outcomes in terms of patient.
What the outcomes you were looking at? Yeah.
So we were looking at infection as primary outcome, and then pain, cosmesis, and wound dehiscence. I guess the cost was also sort of considered a secondary outcome, but we didn't complete a full proper health economics analysis on that.
Okay, so I guess I'm trying to marry up your question with your outcomes, because you said it's just seeing whether it's the burden on the service that you're talking about. So if that's my question, then my outcomes would be number of times they're returning to us, and whether having absorbable sutures is reducing that. That's essentially what I'm trying to see, and the implication on that. Or that could be a finance related issue, it could be a patient experience related issue, having to come to hospital less often. So to me, I think you've done a very good study, but I think the question and the outcomes are not quite matching up.
Okay, no, I completely see where you're coming from. That's
what I mean. It's not a criticism, it's just that whenever we're designing, the question is the most important bit of any piece of research we do. You've got a very, very specific question, and then you've got to get your outcomes, because otherwise you're not really answering the question you've asked yourself.
No, absolutely, yeah.
So that's one thing. So the other thing you'd said was you said it's about trauma, but like you said, when you came to do your study, you actually included non-trauma patients as well. So could you work me through that as well? Because your Prisma diagram was very good and it follows all guidelines. So when you're doing a systematic review, you tend to set out your question and you need to pre-plan your inclusion and exclusion criteria. So given that your question was trauma, what were your inclusion and exclusion criteria that you set out before you did your search?
Sorry, I accidentally just minimized the screen.
That's all
right. So things that we excluded, our inclusion criteria were hand injuries, required closure in a human, and those were our main inclusion criteria. So our exclusion criteria were there initially would have been elective hand surgery. As I've suggested in the Prisma diagram, we've obviously had to include that.
So this is what I'm going to say. This is, again, a very important point with a systematic review. So you set out your inclusion criteria that must be hand trauma related studies. You got to your search and found your results came up as 0 for hand trauma. So what made you, how did you navigate the research process, the systematic review at that point? Because one school of thought would say you're doing a systematic review. If your search came up as 0, that is your result, to say there are no studies looking at the question I've asked. But it sounds like you modified it. And so how did you, as a team, decide to modify that? Because it's not really answering your question now.
Yes, I think, as you've sort of pointed out, the big problem is that we couldn't actually find an answer to the question, not just by pulling answers from papers that existed, but just simply by discovering there weren't any papers really that even answered the question or tried to answer the question. So obviously the study was Prospero registered as per the initial inclusion and exclusion criteria. And so we had initially registered our search terms, so we did have to go back and modify all of those. We really wanted to keep it focused on hand injuries. We could have perhaps modified it to include traumatic injuries anywhere in the body, but because it was really important to us that it was hand injuries, we opted to include elective procedures. That also opened up papers to us where there was no distinction made by the authors in patients who had elective or traumatic injuries.
Okay, that's fine. I think we've just always got to be very careful when we're designing questions and systematic reviews as to what the question is. And the whole process with systematic reviews is obviously about bias. And if you're changing things halfway, then it does introduce a level of bias. So just be wary of that. So my final question relates to the results. So obviously the study was designed to see if you're getting, you can have less people coming back by having absorbable sutures. I guess that's the idea. Do you know from your own kind of population of patients within the team you were doing this in, or from the literature, as to what proportion of those hand injury patients would need to come back anyway for physiotherapy? Because if all of them needed to come back for physio anyway, then having absorbable and non-absorbable makes no difference, because they're still having to return to the hospital if that was your outcome. Whereas if you're saying only half of them would have needed to come back for physio, then maybe you would have been reducing the return by half.
So none of the studies that we looked at actually gave that information. So I wouldn't be able to say, based on the literature, about the percentage of patients who had absorbable sutures but were required to return to hospital anyway, and therefore that benefit of using absorbable sutures was lost, although there obviously are the others. The personal experience of our unit was that they particularly preferred using absorbable sutures in patients they knew were not going to be required to come back for physiotherapy, and therefore it was actually very beneficial. It was less important in patients that were obviously going to be returning.
No, I completely understand the argument. I guess if I were to be on the finance board for the hospital or for a research grant, I'd want to know what proportion of patients would actually benefit from your study to actually spend the money on this research to say, actually, but if if only 2% of your patients were not going to come back to hospital, then probably it wouldn't be worth it. But if you said actually 70% of patients probably could just, not come back, that would be a great savings for the hospital. So it's the rationale at the beginning, but I can really understand why it was done. So well done.
Thank you.
I hope you can rest now.
Thank you very much for hosting.
All right. Bye.
Thank you. I'll add Lauren back in.
Hi.
Hey, Lauren. Whilst you're loading that up, it is actually very interesting in terms of the lack of evidence that we have for a lot of things that we do, especially in surgery.
Can you see that and hear me okay?
Perfect. We can see that very well. Thank you.
Hi, my name's Lauren. I've just finished core surgical training in the east of England. And this is a systematic review I did whilst working at St Andrew's Centre in Broomfield Hospital on thoracodorsal perforated flaps in head and neck reconstruction. So just to start off with some background into the Tdap flap, it was first described in 1995 in the lower limb, and it was kind of designed as a progression from the latissimus dorsi flap. It's got quite a wide application. It can be used as a single constituent, and can be used as a composite flap, and can be pedicled and a free flap. And it can be widely used around the body. So it's most commonly used in the breast and axilla, but it's actually used in upper limb, lower limb, head and neck defects as well. And to date, there's no existing systematic review on its use in the head and neck. So we did a Medline search in April of this year, and I termed both thoracodorsal artery perforator, Tdap flap and TAP flap, and all of the titles and abstracts were screened and checked by 2 authors independently. And then the remaining texts we obtained and assessed independently again by 2 authors, getting data on patient demographics, defect details, flap details, and the outcome data. So here's our prisoner diagram. So the initial search generated 222 papers, and then after the initial screening, 177 were removed, either because they weren't in English language or because they were about another anatomical location, mainly breast. And then that left us with 45 texts, which we further analysed, and then we excluded 8 due to either inadequate detail in the paper, whether there was duplicate data from another study or a wrong anatomical location, leaving us with 37 papers. So we split the results into single constituent and composite flaps. So I'll start with single constituent flaps. So there was 29 papers which discussed 145 flaps, and the majority of those were free flaps. So there was one case series which looked at pedicled flaps in the hypopharynx. The mean age was 39. The most common indication for reconstruction was carcinoma and burns, and the defect size wasn't really reported in any of the papers. You can see it was most commonly used to repair defects in the skin of the face, neck and scalp, but also used in the oral cavity, oropharynx, hypopharynx, the ophthalmic region and the skull base. The mean size was 8.7 by 16.8 centimetres. Most of the donor sites closed primarily. A few required split skin graft. There was a mean of 1.43 perforators and a mean pedicle length of 12.8 centimetres. Of the papers that discussed mean arterial and venous diameter, there were 2.3 millimetres and 3.5 millimetres respectively. The venous anastomoses were typically hand-sewn in an end-to-end manner, and the most common recipient vessels were the facial and superficial temporal facial vessels. In terms of the outcomes, so the overall survival rate of the flaps was good at 98.6%. There was 2 complete flap failures. So one was the oropharyngeal reconstruction, where there was a dehiscence noted at day 8 in the velar portion of the flap. We tried to fix it, but failed and had to be debrided. There was a pedicle hypopharyngeal reconstruction, which was noted on delivery of the flap intraoperatively, so they raised the contralateral flap successfully. There was 9 partial flap failures, so there was partial necrosis due to artificial insufficiency in 8 patients, and fistula requiring debridement in 1. And other complications included temporary venous congestion, hematoma, fistula, infection, fat necrosis, pneumonia, and PE. Moving on to composite flaps, so these were discussed in 9 papers, and there was a total of 18 flaps. The mean age was 49.9 years, and 8 female and 8 male. The common indication for reconstruction here was carcinoma and trauma. And again, the defect size wasn't really reported. So here the kind of most frequent use was in the oral cavity and oropharynx. There was hypopharyngeal reconstruction, nasal cavity and paranasal sinuses, skin of the face, neck and scalp, ophthalmic, and then kind of a large facial reconstruction. So the composite flaps were made up of lat dorsi in 2 papers and the scapula in 7 papers. The mean size was 7.5 by 18.4 centimeters, mean perforators 1.8, mean pedicle length 10.33 centimeters. The arterial and venous diameter wasn't reported, and again, the same recipient vessels. So there was 100% survival rate reported here, but there was 2 partial failures. So one was a palate reconstruction where there was fat necrosis, which required a turnover nasolabial flap for support. Another maxillofacial location where there was a local abscess and partial bone necrosis, which required a forehead flap. Other complications included infection and necrosis of the wound margin. There was no patient-rated outcome measures. So I think overall, the current evidence shows good outcomes in the flap survival rate, and it kind of shows that Tdap flaps can be used to successfully repair a wide range of head and neck defects. However, most of the papers are quite low-grade evidence. They're case reports, case series. There's no kind of evidence at a higher level above that. And only 2 papers reported patient-rated outcome measures, and neither of both were validated tools. So that's more of a kind of weakness of the data. So in conclusion, Tdap is a good option to consider in head and neck reconstruction because it's versatile and there's lots of composite options. But we need to kind of do more research to provide higher level evidence of its efficacy and outcome measures, especially in regards to patient-rated outcome measures. So thanks for listening and your questions.
Thank you so much, Lauren. Excellent talk. For me, my question is for someone who probably doesn't know that much about head and neck reconstruction, but what other options do we have in terms of flaps to reconstruct the head and neck, and do you know how they compare?
So the kind of other main common reconstructive options, radial forearm free flaps. You could use a fibular flap, anterior lateral thigh flap. Those are the most common ones that I know of. And I don't think there's any kind of data looking into comparisons of those that I've seen. And the data that is existing from the Tdap flap, as I said, it's all kind of case series and case reports. So I don't think it's kind of sufficient to make an adequate comparison. And I couldn't really make that judgment from my study because it was just kind of looking at whether Tdap flap was a good option.
Perfect, thank you.
Excellent. Thank you very much. Very interesting study. Lauren, I'm going to ask you the same question I asked the presenter before you. What was the actual question in your study?
So we wanted to see whether Tdap flap was a good and viable option in head and neck reconstruction. So kind of the outcomes to assess that, we're looking at the kind of overall survival rate. That was kind of the primary outcome. And then kind of secondary to that, we're looking at patient-rated outcome measures, although there wasn't many to look at, and other complications.
Okay, so tell me the rationale for it. I know you said that you hadn't found a study that looked at Tdap in head and neck reconstruction. Was there any reason to believe that it shouldn't work? You know, a flap is a flap. No matter where, we know flaps work, regardless where you take it from the body. If you get a flap, it should work. So what is the rationale of you thinking that it might not work? Was that a concern, or?
Yeah, I think especially historically when the Tdap flap was first introduced, there was a lot of concern about its vascularity and reliability. In the breast, it's typically used as a pedicord flap. In its use in kind of the head and neck, where it's more commonly used as a free flap, and the lower limb, which is another systematic review we're doing separately to this. There's not kind of a whole host of evidence that shows it's reliable in that context. So that's why we want to.
In the lower limb context.
Yeah. So kind of that's a separate systematic review we're doing with that.
Okay. So given that your study doesn't really have a comparator, as Taz has asked, you know, what's the gold standard? If you were the patient, would you want to have a Tdap, or would you want what is the current gold standard?
If I was a patient, I suppose it would depend. It's kind of what's
That's what it comes down to. It's patient.
So if it was like a surgeon who could do any flap,
any of them, they can do any of them. You've got a surgeon who is an absolute master, can do all of them, and you're the patient, and you say, you know, which one are you going to do? Which one are you going to ask for?
I don't know.
You don't know.
Yeah.
So in that context, do you think the study has added to the literature if it's not adding to you as a patient? It's not a criticism, it's just a general question when we do general research question.
I think what it's added is it's shown that it's there as an option, and it's an option that can work well.
What would make you choose it if you were the patient and you were looking at studies and you wanted a study to help you decide? What would you want to see in your study that would help you decide?
So, does it work? So, is it going to successfully repair the defect? If it does work, is it going to lead to a deficit from the donor site? Am I likely to get complications from it where I'm going to need further surgery?
Okay. Having a comparator would help if it was a Tdap versus ALT or something. So it's a question again, doing a good question. There's PICO format, which is good for interventions. The other question I would ask you is, you talked about low quality in your studies.
Mm-hmm.
Did you do a formal quality assessment of each of your studies?
So that's, we're still kind of reviewing the paper as we're writing it up, and that's kind of one of the points the senior authors made, that is my plan to move forward with the project. So we're going to look at it with the Institute of Health and Economics quality appraisal and kind of go through.
You're doing this after your study rather than planning it at the beginning. So the only reason I pointed out, and because, you know, these kind of conferences that, you know, Taz has very kindly organised, is, you know, it's all about us kind of learning as well. So systematic reviews, you've got to pre-plan it, set out what you're going to do at the very beginning, because the whole point of systematic review is to reduce bias as much as possible. Yeah. If we modify things along the way and we add things after we see the results, then what we're doing is we're adding multiple sources of bias. So what you should do is at the very beginning say, these are what I'm going to do, this is what I'm going to do, and just stick to it. So it gives you a more robust study. Yeah, so that was the question. So it's good that you're looking at it. I think that's all, actually. Well done.
Thank you.
Thanks so much, Nolan. Perfect. We have Rory Britton next. So I'll add him.
Oh, hi.
Hey, Rory.
Okay.
Trying to try sharing your screen.
It's not not giving me options for anything else to pick other than this.
Can you see the share screen button on the bottom?
Yeah, so it just popped up, and the only thing it's really got, I could say my entire screen. You're probably getting Inception. I mean, I think it's probably not going to work because it's quite an old Mac, but can you get my slide up there without me looking at the rest of you?
So I can see your screen now. I can't see the size you're looking at. So if you bring up your slides, it should, I'm hoping, that will work.
Anything there at all?
Not at the moment.
So I've kind of got not working.
It's still a screen for the actual conference itself, so I'm just waiting to see if it changes at all.
Okay. I'll tell you what, I've got another computer next to me which hasn't got a webcam, so you will lose my face, but you will at least get my presentation, which is probably a reasonable trade-off.
No problem. Fine. I'll move on to the next caller, if that's okay. And then we'll get back to you. All right.
All right.
Do we have Rui Lopez? If you asked to join. Perfect. Thank you, Rui. Hi, Rui.
Hiya. Can you hear me well?
Can hear you loud and clear. Do you want to try to share your screen?
Let me try and share my screen.
Remember to open up the presentation first before you share the screen.
Sorry?
If you open up presentation in plain mode or slideshow mode, it usually works, and then you share your screen.
Mm-hmm. No. No, it does not show the PowerPoint.
So if you're opening up the browser first?
Yeah, it's on the browser.
Yeah, so if you open up the PowerPoint first, put it in plain mode, and then the share screen button, it should work.
Yeah, I've done that, but it's not showing up.
Is the share screen coming up at you or
No.
do you want me to try and add you again?
It might be. Let me just check the permissions.
Are you on the Mac?
No, I'm on a PC, but for some reason it's not allowing me to share anything.
Just for the interest of time, while you get on that, we'll try the next presenter, okay?
Yeah, sorry.
Perfect. So do we have Haneen Abid? Perfect.
Oh.
Hi.
Hi, Haneen.
Hi.
Shall we give it a go? We can hear you.
Perfect. Okay. Let me try.
Third time lucky. Yep, so that's working. Perfect. Thank you so much.
Okay, happy for me to start?
Yeah.
Hi everyone, my name's Haneen. I'm one of the core surgical trainees working in the West Midlands Deanery, and I'm presenting a project on the ever-present costs of cosmetic surgery tourism, a 5-year observational study. So these are the things I'm going to talk about today. So medical tourism describes the process whereby patients travel outside of their home country to receive medical care. Cosmetic surgery tourism specifically describes this in the context of aesthetic surgery. Cosmetic surgery tourism has become a particularly popular option for some of the patients in the UK, despite its risks, and an increasing number of patients are presenting to NHS services with complications. In the UK, the cost of managing these complications is funded by the NHS. However, it's only including emergency treatments and no revision surgeries. The British Association of Aesthetic Plastic Surgeons have performed numerous surveys, but one in particular that reveal that these problems are on a steady increase, with a significant more number of their members recording a rise in complications over the last 5 years. So, having worked at a level 1 trauma centre in Birmingham, the Queen Elizabeth Hospital, we performed a study with the aim to evaluate current presentation patterns for complications in cosmetic surgery tourism, and in particular looking at the financial burden. Doing a literature review showed that there are few studies within the UK that have investigated this phenomenon, and our study over a 5-year period is currently the largest known in the literature. So the methods that we did was we looked at all patients presenting to plastic surgery with complications of cosmetic surgery within the year group within the years 2015 to 2020, and it was any patient that required inpatient treatment. The data was collected retrospectively, and the data included demographic data, types of surgery, complications, and the country of performing surgery. Based on all of this, we used the national schedule of NHS costs to calculate the total costs per patient, and then the total cost of all patients over the 5-year period. So, over the 5-year period, a total of 26 patients presented to our institution with cosmetic surgery tourism related complications, and a total of 32 cosmetic procedures were recorded, either combined or performed, but they were all performed within one single sitting. A total of 25 patients required inpatient stay, resulting in 163 days in hospital, with the mean length identified as 6.5 days. In terms of the demographics, all patients were female, and the mean age was 35.1. I did also look at the ethnic diversity of patients, as shown here. So in terms of the most popular choice of procedure, it was quite evident that abdominoplasties was the most chosen procedure choice, with 41%. There was a number of patients that had abdominoplasties in addition to gluteal and breast surgeries, and that was a total of 62%. The remainder of procedures are shown here. In terms of the country of origin where the cosmetic surgery procedures were performed, Turkey seems to predominate, with 54% of patients going to Turkey. This followed with Prague, Dominican Republic and Poland, and one patient went to Iraq, USA, South Korea and Cyprus. In terms of the complications, the most evident complication that we had noted was wound infection, and this was followed closely by wound dehiscence. 5 patients required removal of implants, with 4 having infected breast implants and 1 with an infected chin implant. Some were noted to have fat necrosis, and 19% had multiple complications, which was noted to be primarily a combination of wound infection, wound dehiscence, and skin fat necrosis. 1 patient was profoundly anemic and required transfusion whilst an inpatient. All patients are managed at the level 1 care on the ward. So, in terms of a summary of the costs that we calculated, we looked at the ED costs, the length of patient stay, the cost of inpatient stay, and the cost of investigations, operative procedures, and outpatient clinics. This table here displays all patients that had an abdominoplasty, plus or minus any other procedures. As I mentioned earlier, there were a few patients that had a combination of abdominoplasty, gluteal enhancement, and breast surgery. So this table looks at 19 patients, one of which was the anemia. The remainder of the 18 is the total costs as shown here. So as it was the most popular choice of surgery, it did have the greatest cost burden, with a total cost of £103,000 or £227 to the NHS. This table looks at the cost of the single most expensive patient versus the cheapest patient, as you may say. So the chin implant patient was a total individual cost of £13,418. And the thigh lift, who presented with a wound infection, was £362, but that's noted the fact that that patient didn't require surgery. In terms of the financial burden over the five-year period we included at Queen Elizabeth Hospital, the total cost we calculated was £152,946, with the average cost per patient being around just under £6,000. A total of 19 patients required surgical intervention, and as expected, this accumulated to the majority of the costs. As mentioned on the previous slide, the most expensive patient was the chin implant patient, as you can imagine, removing the implant would actually require more than one procedure. In terms of the discussion, our study did demonstrate the presence of an existing problem, and there is a number of studies out there producing similar findings across the world. So these three in particular that I did look at, Thakur, Miyagi and Asher, also produced similar findings with similar costs. There are several documented factors motivating patients to travel abroad, but it is noted to mostly be related to cost saving. Some postulated theories do include that there is a lower threshold for operating despite patients' comorbidities, including BMI. There are restrictions in the UK on these factors. Also operating on smokers. BARPs mention that they don't operate on patients that have been smoking cigarettes within a certain period of time, which isn't quite evident on some of these other countries. And additionally, there is a short post-operative monitoring period, as patients tend to be discharged early and travel back to the UK with no follow-up. With these complications imposing significant cost to the NHS, we have suggested to invest in patient education campaigns and particular medical tourism. A suggestion from BARPs has been that hospitals to invoice foreign providers for cosmetic surgeries with the cost of treating complications, but this is currently not under play. Additionally, the Joint Commission International and several further international collaboratives have been launching contracts for medical tourism that would ensure accountability. However, again, this is not fully in play. In terms of the limitations of our study, we only included the patients that were within the plastic surgery department, but there is a number of patients that may have presented to general surgery, as many breast abscesses do fall into the general surgeon's hands. Additionally, we couldn't include patient transportation, psychological costs, and some other costs that weren't available on the NHS schedule. So in conclusion, the practice of medical tourism, which is variably regulated, is not without risk. And this can lead to complications that the UK are often managing, and it is a direct cost to the National Health Service. The cost displayed in this study should be viewed as a reflection of the detrimental effects that these complications can have. And we feel that the global governing bodies should focus efforts on educating patients on the risks associated with cosmetic surgery tourism, and achieving these will in turn reduce the cost to healthcare systems. Thank you for listening.
Perfect, Henry. Thank you so much for that. I think it's a really important topic. Actually, I read a I think it was a Guardian article actually a few days ago, in terms of they noticed a 50% uptake in website visits for cosmetic surgery over the last few months, and they're attributing it to Zoom, to basically all the Microsoft Teams and everyone having their face basically in direct vision with everyone. So I think that's a very important talk. How do you think the current situation, the current climate is going to change cosmetic surgery and the tourism aspects?
So having spoken to a number of colleagues, and also a study that we are doing at the moment, there has been a significant reduction in the number of uptake of cosmetic surgery tourism as a result of the restrictions of COVID-19. However, these cosmetic surgery clinics are operating in the UK. So patients are able to have video consultations and socially distanced consultations within the UK, having had some relaxed rulings at present. So I do feel that it will go back up eventually when the borders do open a little bit more. And Turkey's currently not on the self-isolation country list. So
And my second question, before Robo asks hers, is in regards to your methodology.
Yeah.
How do you think you can improve the strength of your overall study in terms of getting a clearer picture of what's going on across the UK?
So what we would like to do is expand this to rather it being one level one centre to being a national thing. I know that one of the studies has been performed in Cambridge, and it's a very similar study to what we have done. But what would be useful is every level one trauma centre across the UK to collate data to have a better reflection of how the National Health Service and the cost burden the National Health Service is using. Additionally, not all studies are using the similar cost calculation that we did. We felt that having done the research that this was the best, as this is directly from the National Health Service, and it is a breakdown of specific operative procedures and the costs of specific operative procedures. For example, breast implant removals, there is a specific cost for that. So.
Perfect, thank you.
Excellent. Haneen, a very, very well done and well presented study. I really like the fact that your outcomes all matched up with your questions. As you can see, I have a bit of an issue with questions and outcomes, so that's very good. I'm going to just follow on from Taz's question on improving the study, because it was already excellent. Okay. You said that it's probably an underestimate of your costs.
Yes.
So, did you have anybody from finance involved in the study?
So, in our trust, there was an individual that I contacted to receive this national the schedule, and there was specific costs that the Queen Elizabeth Hospital have for the procedures, and I compared them prior to doing the cost calculation to see if, for example, the QE costs were slightly different to the national costs, but they are actually quite similar. So I felt that it was a reliable source to use to calculate the costs.
Yeah, so what I'm saying is, in part of your research and improving the method, having people do the finance on a daily basis.
Of course, yes.
Having like a core research team is actually quite helpful. They they will know about.
Oh yeah.
But not just missing, just they know of all sorts of extra costs that as clinicians we're not very aware of, and they go, you know what, there is an additional cost of the hospital that you didn't count, and then you find by the end of it you find that your costs have doubled because they're aware of it. So it's just a way of improving. We're looking at a finance type of study, having them involved, because I see the 3 authors are all clinicians.
Yeah.
Whereas we mustn't forget we've got non-clinician members of teams for research who can actually really add greatly to these studies, because we're not experts in everything. I'm not saying that you didn't do your best to get the finance, but it can help a bit. Did you think about including people who didn't require inpatient care, because actually they would have added to costs as well, maybe a bit smaller? And do you think that was the number of those patients was going to be high or similar?
We did consider it, but the difficulties that we faced were the way I collated the data was based on coding, and if the patient presented to A&E with perhaps a minor infection that could be managed with antibiotics and they were sent on their way, they wouldn't fulfill the coding criteria that would allow me to identify them as a cosmetic surgical tourism complication. Right. So it was something that I definitely did consider, and I did think that this would be it would probably be significantly increased, because there are lots of patients that have, as you can imagine, with smaller infections or things that can be managed in primary care setting. And I think that is definitely
sorry, go.
No, that's definitely something that is worth considering, but it was more the ability to get that data and for them to be coded correctly for me to include them.
Yeah, I mean, I guess I've come across patients who have come in because they're unhappy acutely, but actually didn't have an acute problem, so we sent them back to the original person. So I'm going to ask you 2 more questions. One relating, again, it's a very general question about research. You have 3 authors on this study. Very important question with any kind of research. Do any of your authors have a conflict of interest?
No.
We think about all 3.
Well, I have a consultant plastic surgeon.
Let's say you do private practice.
No, I appreciate what you're saying.
So, if you have an author, any author, who's private practice, and you have a study that's showing that having surgery elsewhere is detrimental, do you think there's a risk of bias? Of
course.
Is it in the interest of one of your authors that the study shows there's a detrimental effect?
I appreciate what you're saying, but I don't think in my authorship that was particularly a problem.
But no, it's a 3-person study.
Yeah, of course.
You're senior author, and you need to declare that when you're doing any study, if there's any level of, and then if you try and submit it, there will be that question: is there a conflict of interest? And that may be a financial one, it may be an ethical one, but you've got to really think about it, because because the next question that I think Taz has also said about, how do you improve it? If you think of a national study, and in your study you kind of suggested BARTS has provided some support or shown some other studies, you've got to think about a national body.
Of course.
Does BARTS have a conflict of interest?
Well,
should BARTS members have a conflict? Should BARTS be doing this? Who should do this study?
Yeah. You are. Yeah. That's an interesting point. Yeah.
Think about who does the study.
Yeah. No, that's definitely an interesting point, and it is, to be quite honest, it is because these procedures are being done by plastic surgeons that don't necessarily work in the UK, and if you have a cosmetic procedure in the UK, the first thing that the NHS will do is send them back to the hospital that performed them, but we can't physically do that because of the logistics of that. So no, I completely appreciate, and that is a very important point, and I take that on board.
And that's not necessarily just for cosmetic surgery, that's for any kind of research. Where's the funding coming? What are the conflicts of interest? Large pharma companies do studies and then they show the results. So we're very, very careful about that, because we want clear, transparent research. So we've got to think about our own interest. And even though there's no authorship lack of confluence for you, but if you're trained to be a plastic surgeon, I could argue that it is in your interest for planning your future career and your practice that this is a good study to have in the background. Okay, so another very final question, I'm only asking these questions because you've done very well, is more of a question of why we've done this study. In it's a cost related thing, so you've suggested we do patient education. Okay, so patient education to show them that if this is, I guess, if we're going to put broad categories, is that this is risky behavior. Okay, going abroad, going and not having follow-up, etc. So this is risky behavior. So what do you think of other risky behavior? Should we not fund people who are doing extreme sports, who are, smoking, 24 hours a day, any kind of risky behavior? Are we, as an NHS, are we not going to look after people who have demonstrated risky behavior despite patient education?
I think that is a very, very good point, and I think what it comes down to is it's a personal choice. It's a free society, and you are entitled to do as you wish to do. But I think what this project is probably displaying is that you can have these procedures if you want, but you can have it done in a safer, perhaps arguably safer environment. And what that could be, and this is probably my opinion rather than a research, but this is my opinion, is you could say that this could be better done in a country where you actually are resident. So if you had any problems, you could seek help. Or the other argument is that you stay long enough to be able to be followed up by the primary team. So there's a number of factors that are in play with this, and I think that it's very hard to say to someone that you can or can't do something.
Yeah, and that's the question about any kind of risky behaviour. We just think about that in the study. Are we not going to treat people who come back with complications from whatever, whether it's extreme in Jamaica, or are we going to limit them?
And I think from personal experience, where this study stemmed from is whilst working at QE, I'd seen quite a lot. And I think what was really interesting about it is, which I did mention in my presentation, is that the NHS will support emergency care for these patients, but they won't do revision surgeries. So if you're going to remove an implant, we're not going to say, "Oh, come back in 3 months' time and we'll put it back in." That was an important point, and I put that on my presentation for that reason.
Well done, thank you.
Thank you very much for your time.
Thank you so much.
Thank you.
So can we try Rory again? Thank you, Rory.
Hi there. Can you hear me? Okay.
Yes, we can.
Okay, let me know if the sound goes a bit odd. Right.
No problem. You sound loud and clear at the moment.
Right.
Perfect. Yeah, we can see that really well.
So you've got slides up?
Yes, yeah, we can see that.
Okay, so hi, so I'm Rory Britton. I was formerly working as an SHO across site at the Imperial College Healthcare Hospitals in London. And I'm going to present a couple of cases relating to partial flap failure in patients developing COVID-19 infection. Without getting too much detail into coronavirus, because we've all heard of it by now, these were two cases that were performed in early March, shortly before we suspended all non-life or limb-threatening surgery. We had already suspended some less urgent free flap surgery. And so one of the cases of free flaps, that's tissue transferred on its own blood supply and anastomosed elsewhere, and one is a pedicle flap. And just to give a bit of context about flap failure, it's been touched on by one of the other talks, but this one study I've quoted here gives a total flap failure rate of about 0.8% and a partial flap failure rate of about 3%. So this is not all that common as a complication. And I've just put a graph on the slide just to show where we were, so mid-March before things got bad for the first time. So to crack straight on, this is a 65-year-old gentleman with paranoid schizophrenia who had self-inflicted deep burns to his scalp and forehead. So the forehead was down involving bone, and there was full-thickness skin burns covering much of the rest of the scalp. He had arrived to us after his initial management at the Regional Burns Centre, where he had had a wound debridement, some meshed allograft and a vac dressing placed. And once we'd managed to get the sort of transfer in place, was coming up to 3 weeks before we saw him for our procedure. So he had a left latissimus dorsi muscular flap raised and placed over the denuded bone, which was burred until bleeding and anastomosed onto the superficial temporal artery. There was initially a bit of a problem with the arterial anastomosis, which was revised intraoperatively and to satisfactory Dopplers. And then the flap was covered with split skin graft taken from the thigh as a sheet over the flap, primarily, but it also expanded into mesh over remaining defect. And post-operatively, he did well to start with. So for the first almost 2 weeks of his post-operative recovery, we had no particular concerns with his flap. His recovery was unfortunately complicated by him developing small bowel obstruction at day 3, and the general surgeons took him for a laparotomy and adhesiolysis. But he recovered well from that and was doing well up until about day 11, and when he developed fevers without any particular typical COVID-19 respiratory symptoms. There was some concern that he might have a little bit of infection in his laparotomy wound, but we were just monitoring that at the time. Subsequently, about 4 days after his positive COVID test, we noticed that the flap on the right anterior aspect, the skin overlying it had started to lift up and blister. And there's that picture from day 15 on the slide there. The flap, then we were sort of subsequently monitoring and actually noticed there was a progression of necrosis. So initially concerned about skin graft loss, then superficial necrosis of the flap. And as we progressed into 44 days and 68 days, we see that the patient was left with a relatively well-healed flap in the majority, but this punched out area where the bone is denuded and the flap has been lost totally in that area. Interesting of note that you can see around the margin of this bone there is healthy flap, so it's not at the margin that the flap has failed, it's centrally. So this chap spent quite a long time in hospital. He hadn't really had any particular clinical consequences apart from this of COVID-19 infection and was discharged after 66 days. He came back as an outpatient 100 days after his first procedure and had Integra to the denuded area, which shrank the defect but not completely resolved it. And then he had a radial forearm free flap, which was performed over the remaining defect and healed very well. And this is him at day 129 after his first LD flap. Moving on to the second case, we have a similar sort of case in that this is a 59-year-old lady who had a locally advanced radiorecurrent vulval squamous cell carcinoma. And she had quite extensive gynecological excision, a vulvectomy and vaginectomy. and we repaired the defect with a pedicled ALT flap, which was punctured twice in the middle with an incision for the urethra and a second one for a drain into the cavity behind. And this lady did have some problems with the flap initially. So day one, we noticed some demarcation of the posterior flap and venous congestion, which did progress. So you can see the first picture there is at day 14. So that area did unfortunately not do well. But the rest of the flap we were quite happy with. And in a similar story to the first case, 17 days in this case after the surgery, the patient developed fevers, a bit of cough, and had some loose stool, and a swab was taken for coronavirus, which was positive. And once again, 4 days later, in a previously healthy area of the flap, we noticed a new necrosis of the flap. So she was treated with dressings until her coronavirus status was negative and was taken back to theatre. This is 3 days after the second operation where that necrotic area has been debrided. And unfortunately, this lady had a very rocky post-operative course. She went back to theatre 4 times in total for debridements and had a further V2Y advancement flap done at day 84. Again, there was no particular major COVID-19 respiratory illness. There was a wound infection, but this was some time after the flap. And she stayed a total of 125 days as an inpatient. After discharge, she still had ongoing issues with the wound, so it was not quite out of our care then. So a very prolonged course. So broadly, I'm showing some early evidence that COVID-19 infection may cause problems in flap surgery. So there's 2 cases who've had delayed flap failure, of partial flap failure, and without significant coronavirus respiratory illness. There was no other local factors such as wound infection at the time of failure or any other change in our management to suggest another cause for failure. And it's quite well established that in COVID-19 infection, there's quite widespread microcirculatory changes, thrombophlebitis and endothelial inflammation. And in transferred tissue, the collateral circulations are going to be less well established, so this tissue is potentially more vulnerable to these changes. So the take-home message really is that beyond consenting patients for the risk of contracting COVID-19 illness and developing respiratory infections, you have to bear in mind that there may be an increased risk of their surgery failing should they develop this complication. And this is particularly relevant if we're going into a second wave, as it seems to be at the moment. So thanks very much. Any questions?
Brilliant. Thank you so much, Rory, for that talk. My question is in terms of how do you, in terms of obviously your presentation was a case report of 2 different cases. How do you think we should, as a research community, research this more and research the effects of COVID-19 in terms of our flaps, and how and what kind of precautions should we be taking in the future, considering we're probably going to get a second wave and we might never get rid of the disease itself?
So obviously, a lot of what everyone is doing at the moment is surgery is being rationalized, and we are doing less until we know more, is generally the approach that is being taken. Obviously, there is another case report that has surfaced in the last couple of months or so about similar sort of flap issues in patients that have had coronavirus. So it's a sort of emerging body of evidence, but it is certainly it's difficult really to generate a lot of high quality evidence at this early stage. I mean, certainly we could try and get a national database of free flap or flap surgery being performed and comparing outcomes to those who develop COVID infection during their hospital stay. But obviously everyone's aim is that no one gets COVID infection during their stay. So I think that data, I think, is going to emerge very slowly, particularly given that we're not doing very many of these surgeries, I think, across the nation at the moment. There are obviously, you could do perhaps some more laboratory-based studies where you could sample tissue and see, actually looking at dead tissue that's happened in flaps and see how that looks to the histopathologists is one idea of how we could generate some more objective evidence. But again, that's going to be fairly small numbers.
Yeah, I think there's multiple ways that you can investigate it, all the way from lab based to actually more trial based. I mean, the outcomes are quite rare, and a good study design for rare outcomes are case control studies, and you can pick those that have failed and work your way back, and that might be a way to tackle to produce a larger study and to actually see the actual consequences of it as well.
Yes, excellent presentation, Rory. It's unfortunate for those patients to have gone through such a difficult period, and I guess it's a little bit difficult because obviously during this COVID period, patients like these patients who are actually acutely, you know, they have tumour or they have burns that were done, and most other kind of elective flaps were being delayed. So I guess, you know, you can just say that let's avoid doing it. So I guess, and I think what Taz has raised is really important. You know, where do we go from here? And from your point of view, how do you differentiate, do you think, with what you've got at the moment, how do you differentiate between someone who has a complication because of COVID and someone who's got a complication and also just has COVID separately? You know, it's having COVID, you know, getting a complication with COVID or because of COVID.
So, I mean, both cases have got confounding factors, certainly. So, I mean, our first case with a return to theatre under the general surgeons, and the second case, quite a lot of comorbidities that might be less optimal for flap surgery. However, I think what in our stories sells the idea of this being related to COVID is that actually it doesn't follow the normal pattern of flap failure. So flaps, when they fail, will typically fail earlier. And actually these patients got out of that higher risk time, developed COVID infection, and then developed flap complications. That was what was forming the link in our minds. Other things that we looked at is actually what happens in patients who've got other coagulation abnormalities, so sort of acquired and hereditary coagulopathies. And there's a few case reports of those, and almost all of them report that actually these patients have flaps that fail on the table. So there is, I think it's the timing that creates the link, but admittedly it's two case reports and it proves nothing. But I think it's an interesting theory, and I think whilst we're trying to avoid further problems, I think it raises a good point.
Yeah, and I guess it's that difficulty of, like you said, you know, two case reports in themselves they're not really high level of evidence, but at the same time, some of the more interesting trends that we've subsequently gone to investigate have started from someone noticing something that hasn't been quite right, which may well be the case. I noticed with your first patient, there was also an inflow problem to start with. Had you, so in your unit, I mean, putting aside what we might do as a bigger research group, in your unit, how are you taking this forward in terms of your management of patients requiring reconstructions? Has it changed practice?
So, I mean, it was something we had discussed internally. These were, as I say, performed just before we stopped doing anything that wasn't completely life or limb threatening. And I think they probably were the only perhaps cases that were performed at that time, but actually they have returned to doing more elective free flap surgery, such as DEP for breast reconstructions. I say it's elective, it's trying to do them as primary procedures on a cancer weight. So it is, I think, something that has been factored in, but they're all, you know, we've got better pathways for keeping, you know, green pathways for trying to reduce the risk of COVID infections in hospital. But how robust those can be, I'm not sure what the data says. So I don't know whether or not this has directly changed management, but certainly it's provided evidence that this is something we need to be really careful about.
And in terms of changing practice, would you consider, because the first one was a muscle flap, would you consider something like a venous coupler? Do you think that would have made any difference in terms of figuring out exactly when the problem started?
I'm not sure, to be honest on that. It's not something I know a huge amount about, I'm afraid. Sorry.
Okay, no, that's fine. I had another question, which was, I guess it was relating to the first case. You know, like I mean, at the moment, when you've only got two case reports, you've got to really analyse what you have and try and match it to other similar cases, as Taz had suggested. So, your first patient, I think I'm a little bit, you put it in as a case report for COVID only, in that it had an inflow problem to start with, and then it had this patient quite a large insult because they ended up with a bowel obstruction and needed to go for a GA on day 3. And usually patients are not so well when that's happening, and it's quite difficult to differentiate between what happened during that period that may have affected your flap, even though I know the noticeable kind of complete kind of partial failure was a little bit later. A little bit of a concern about that, but it's just overall, I think it is really interesting to present these things so because we may well start seeing it elsewhere, and it's something to bear in mind, I think. Thanks very much.
Perfect. Thank you so much, Rory. Perfect. Can we have Rui on again, please? Hi, Rui.
Hiya.
I'm going to try sharing your screen again and see if it works. Perfect. Thank you so much, Rui.
Yeah, can you see it?
Yeah, we can see it. And you're loud and clear.
So, hi everyone. My name is Rui. I developed this study during my year as a clinical fellow, junior clinical fellow at St Andrews Centre for Plastic Surgery, and we looked into patient-rated, photochromatic, and peer-reviewed outcomes following mid-phase reanimation surgery with the 2-stage free gracilis muscle flap. So just a bit of background. So the main objectives in facial reanimation surgery, it's for patients with unilateral facial palsy, is to bring back the facial symmetry together with the spontaneity of smile. And as a gold standard, the 2-stage reconstruction with cross-facial nerve graft followed by a free gracilis muscle transfer is the treatment preferred by the majority of surgeons. The free gracilis is preferred because it's relatively easy to harvest, has a reliable anatomy, and minimal donor site morbidity, and an excellent contractile strength. And by using a cross-facial nerve graft, you can take advantage of the contralateral healthy facial nerve and provide spontaneity and emotional reactivation of the smile. The literature is quite heterogeneous, so there's a lot of papers that focus on 1 stage, some on 2 stage, others on just using cross-facial nerve graft, and some on using cross-facial nerve graft coupled with a different nerve. So in our center, we looked into patients that had free functional muscle transfer with the gracilis in a 2-stage procedure using either cross-facial nerve graft alone and cross-facial nerve graft with the mesenteric nerve as well. And the question is this 2-stage procedure with either innovation a good option to provide minimal morbidity, and good patient outcomes? Is it a good option to provide symmetry, both static and dynamic, to patients with unilateral long-term facial palsy? So just very, very brief of the surgery. So in the first stage, we harvested the cerebral nerve, use it as a cross-facial nerve graft tunneled over the under the upper lip, and banked it on the contralateral healthy side. In the second stage, after the Tinel sign is elicited on the cross-facial nerve graft, the gracilis is harvested, and then a pocket is created, as you can see in the diagram. A pocket is created on the affected side. The gracilis is then banked on the affected side. The tendinous part is stripped into 4 strips and sutured to reference points around the orbicularis oris muscle and the medullus to recreate the contralateral fold, nasolabial fold, and the smile. In our study, so we looked retrospectively to the whole practice of St Andrews Centre, mostly under just one surgeon that does this procedure. We collected demographic, perioperative, and postoperative data. We used preoperative and postoperative pictures and analyzed it with the facial metrics software to assess symmetry and improvement or detriment in symmetry. We used preoperative and postoperative videos and asked independent raters to grade them subjectively with the TERSIS and NOAA functional and aesthetics grading scale. And those same 3 independent raters assessed blindly for synchronicity of smile using the technique described by Dusseldorp of time stamping. And then finally, we called all the patients and asked them to answer the Glasgow Benefit Inventory questionnaire to assess patient-rated outcomes. So in terms of the sample size, we had 28 patients that have undergone that procedure in a two-stage fashion. 57% were just cross-facial nerve graft powered. 43 had dual innervation, 1-to-1 ratio, mean age of 33. 61% had complete facial palsy with no recovery. 39 had partial facial palsy. Etiology, most of it was secondary to tumor resection and iatrogenic, followed by idiopathic and then trauma. We had 6 complications. 3 were seromas drained underlocal. 1 was a wound dehiscence. 1 was a donor site infection. Sorry, missing the infection. Donor site infection required washout in theatre. And the other one was a flap failure secondary to a hematoma. And that patient went to have another gracilis, the contralateral gracilis, for reconstruction. So it's still included in the study. 22 patients had revision procedures to perfect symmetry, and the mean duration of follow-up was 5.5 years. So, like I said, we used the facial metric software called Emotrix, computes about 60 landmarks in the photo, and automatically calculates symmetry different in different positions. So we had pictures in repose, closed-lipped smile, and open-lipped smile, both pre-op and post-op. And this is the analysis from Emotrix for all the patients. So it's a quite complicated chart, but in essence, all measurements, so for repose, closed-lipped smile, and open-lipped smile, improved from pre-op to post-op. And most of them, as you can see, improved significantly, mostly in the closed-lipped smile and open-lipped smile. And then we subdivided, comparing patients with cross-facial nerve graft only and dual innervation. Again, there was very mixed results. In some measurements, a cross-facial nerve graft was better. In others, dual innervation was better, but there was no significant difference between those two subsets. Looking into patient-rated outcomes, overall there was an improvement. There was a mean total score of positive 35, going from -100 to positive 100. 16 patients reported that they felt that the surgery improved their facial symmetry and their subjective outcomes as well. 1 patient felt that the reanimation had been detrimental. And then looking at peer review, like I said, we had three independent blinded assessors that used the TESA scale as is provided in the picture. 12 patients had an improved score, 9 had no change in score, and 2 the raters felt that they had a worse score. Overall, there was a significant improvement of the mean preoperative to postoperative score, with a relative gain of about 55% in symmetry. Looking into synchronicity of smile, the synchronicity was 93.3% in all patients assessed. And we used the time-stamped method, like Dusseldorp described as it is described in the pictures. So here we have a few results of the patients that were included in the study, with A being pre-op and B being post-op. And then finally a video of the ones that we analyzed with pre-op and post-op in several positions: repose, closed lip smile, and open lip smile. So overall, we concluded that the two-stage free gracilis muscle transfer indeed improves the static and dynamic reanimation of the mid-face, and the objective analysis and subjective analysis, taking into account the patient's self-reported outcomes, show that this is a low morbidity procedure with apparent improved psychological well-being. In terms of limitations of our study, obviously this is a retrospective study in Nature, so and based on a single center, so may not have as external validity as if it was a national study. And then there's the inherent issue of missing data as well. for patients with incomplete photograph sets and video sets. But the main limitation that we found, particularly when trying to compare this with series already published in literature, is that there's no universal adopted outcome measurement tools. So people use different objective tools to assess patients' pictures, and that it makes it completely impossible to compare results with different studies. However, we do feel that this technique generally improved symmetry and both static and dynamic to all the patients. Thank you.
That's going to take a while. Thank you so much, Ruby, for that. That was a brilliant talk. I love the range of outcomes in your study in terms of looking at both the patient and the clinician, and that range between objective and subjective as well. That's brilliant. I think a lot of studies should be doing that across the board. Much about the topic as well. What other options do we have in terms of mid-face reanimation, and how do they compare as well?
Yeah, so there's a wide range of things that can be done. So it can be done as a single procedure, just one stage or two stage. In terms of evidence for doing one stage to two stage, it's not very clear. Some studies say that two stage one stage is better because it's just one single procedure, has minimal morbidity compared to two stage. But other studies said that the delay between doing it two stages permits the axon regeneration of the over the length of the nerve of the cross-facial nerve graft, and then limits and minimizes the denervation period of the transferred muscle as well. There's also a wide range of described muscles used for mid-face regeneration. The gracilis is overall the preferred one for the reasons that I stated. And in terms of nerves used, there's a consensus in using cross-facial nerve graft, with being the sural nerve, the harvested one. But then some studies, particularly the most recent ones, tend to do dual innervation procedures. And the hypothesis behind it is that the cross-facial nerve graft will provide the spontaneity of smile, whereas the other nerve, in most cases is the mesenteric nerve, will provide the contractile strength to the gracilis.
Okay. Thank you.
No worries.
Well, thank you very much. It's a very nice study and very well presented. And I agree with Taz. It's really nice to have a range of very well looked at outcomes from patients that have some peer review. So well done on that. That makes it nice.
Thank you.
In your conclusion, you said that this shows that the gracilis does improve the outcome. And you've also said that there's a range of other muscles that we can use, but overall this is the trend, or this is a preferred method. So tell me, what do you think your study is adding to the literature?
So compared to the studies already published, we have one of the biggest samples, but I think the strength of this study is that we provide patient-rated, which is most of the times not provided in any studies, patient-rated outcomes, objective and subjective, and we're trying to create a trend where, without all our head and neck studies in facial palsy, of always using the same measurements of objective analysis and subjective analysis to make it comparable when people want to compare to our study. And I think that's the strength in the study. The landmark studies from TERS that look into this focus more on the subjective side. They use TERS and NOAA scale, and tend not to use patient-rated or objective analysis. And the more recent studies tend to use a wide range of objective analysis with 3D cameras and all that. And most centers do not have that capability. So this Emotrix analysis that is available for free on the internet has been validated before. And is starting to grow in strength in the literature. So hopefully in the near future we'll have a more wide range of studies that make it comparable.
Okay. So is your your outcomes with patient-reported outcomes, the first study in the Brazil showing this for facial reanimation?
Sorry, I didn't catch that.
Is your study the first study showing patient-related outcomes for
No. So there's 2 other studies that show patient-rated outcomes. They do not use the GBI scale. They use a scale developed by themselves that has not been validated. The GBI is more extensive in the way it assesses social outcomes, psychosocial. It's quite extensive, and it's been validated before for other procedures, not only facial plastics ones. So we believe that that's the best scale to use.
Okay, so I guess my other question is, like I said, you kind of alluded to this yourself, that it's quite difficult to compare studies because everybody seems to be using their scale of some sort, and this I think is particularly true of facial palsy. There seems to be lots and lots of kind of scales that each centre has developed as their own. As a wider research trust, why do you think each unit is developing their own scale? How do you think we mitigate this kind of difficulty of comparing research?
I think particularly in objective analysis, there are a lot of study groups that are creating algorithmics and computer programs to analyze pictures, and instead of focusing and using the ones that have been validated and show good results in a wide sample, they're trying to always perfect them, create new ones without perfecting the old ones, and without.
Why do you think that is? Why do you think that is? Why do you think people do their own thing as a research group?
I think because it makes it more publishable.
And research driven by, you want to publish something, your next grant comes from the research publication.
Yeah, and if you obviously, if they're developing a new way of analyzing objective outcomes, they're going to publish a study describing that way, and then they're going to publish a study with the computer program they used. So it's a lot of publications coming out of just a new facial metric software.
Okay, so this all comes back down to research ethics and research methodology and conflict of interest, because again, for example, for all of you here, if you just write another paper that's an existing technique with a little modification, you're probably not going to get that published before your ST3 applications. And you need one. So it is better for you to develop something new in your department, even if it's on a smaller sample, to get that paper. So what I'm just demonstrating is that there are conflicts of interest. And so in this particular area, it seems to be going on for a while. So what might be your solutions to try and, you can understand why it's done. Each unit does need their grant application. People do need to publish. How do you get around that to actually make it better for the patient?
I think that if we already have the scales that have shown validity, if we publish something proposing a way of subjectively analyzing patients with facial reanimation surgery, and describe it well, how to use, make it accessible for everyone, show that this is a way of comparing the results. Because most of this one stage versus two stage and mono innovation versus dual innovation, the way that no one knows which one is the best one because there's no way to compare it. The results are so scarce and people use different things, it's completely impossible to do a meta-analysis. So I think the best way would be to propose a way of analyzing of doing facial palsy papers or facial surgery papers by providing an objective analysis measurement, subjective analysis measurement, and a PROMS scale that everyone can use.
Would you consider doing collaboratively proposing it, or would you like to do it yourself?
Oh, I could do collaboratively. I don't mind.
Okay, excellent. Thank you very much.
Thank you.
Perfect. Thank you, Lee. So last but definitely not least, we have Elizabeth Murray. Do you want to invite yourself? Perfect, thank you.
So, hello?
Hey, we can hear you.
Brilliant. As you can see, I'm in Scrubs, I'm at work, so I hope the NHS internet holds up okay. Just let me know if there's any problems.
Hopefully you don't get bleep.
I've handed my bleep off, so let me just share my screen with you. Okay, is that all right? Can you see my slides?
That is, yeah, that's perfect. Thank you so much.
Brilliant. Okay, good afternoon, everybody. My name is Elspeth Murray, and I'm a CT2 in the west of Scotland. I'd like to discuss with you our systematic review and meta-analysis, which is looking at the effectiveness of pharmacological adjuncts for the prevention of adhesions in hand flexor tendon surgery. It's well known that zone 2 injuries can be quite surgically challenging, and part of the locally administered substances have shown promising results for jaundice, and this has been as far back as 1970s. The substances which I'm talking about are listed here are sodium hyaluronate, which is derived from fibroblasts and works as an anti-adhesion barrier, which is over time absorbable by the human body. Adcon-TN is similarly absorbable by the human body and also works as an anti-adhesion barrier gel and is made by porcine.
Your talk is disconnected. Is it just me?
Sorry, hello? Did you say something, Taz?
Yeah, do you want to? I think you disconnected for the last about 20 seconds or so. So you can repeat what you said in the last 20 seconds for the last time.
So I'll just repeat this slide. So the background to what we were studying is that zone 2 injuries can be very surgically challenging. This is due in part by the complication of post-operative adhesions, resulting in reduced range of movement and compromised function, necessitating further intervention. The main current advocated intervention is physiotherapy, and this is backed up by systematic reviews to say that early active mobilization has been effective. Locally administered substances, such as those here, have shown promising results predominantly in animal studies, and this dates back to the 1970s. Sodium hyaluronate, sorry if I'm repeating myself, but sodium hyaluronate is derived from fibroblasts and is absorbable in the human body over time. It works as an anti-adhesion barrier gel, as does Adcon-TN, which is also absorbable over time. It is made from porcine gelatin. PXL01 is made from human lactoferrin and is coated to increase tendon strength and reduce adhesions not only in hand surgery but also in abdominal surgery. And lastly, mannose 6-phosphate inhibits transforming growth factor, which then in turn reduces or is coated to reduce the creation of post-operative adhesions. So the aims of our study were to present all the published evidence of these adjuncts used in preventing post-operative adhesions after digital flexor tendon surgery in the hand, and to our knowledge, no previous systematic review or meta-analysis of RCTs exclusively has been done. We used PRISMA guidelines, and we included patients undergoing flexor tendon surgery in the hand. The intervention was any of the pharmacological adjuncts that I've already described, used to aim to reduce post-operative adhesions. Our controls were other interventions, placebo or no intervention, and our primary outcome, which was found as an outcome heterogeneous over all the studies we looked at, was the active range of movement of the affected finger as a TAM measurement, the sum of active MCP, PIP, DIP arc of motions. The follow-up was broadly classified into short-term, mid-term, and long-term. So as I've said, we've used RCTs exclusively, comparing pharmacological adjuncts with any other intervention or none, and we excluded any papers that weren't in English, were in animal studies, were in non-randomized studies, or in pediatric populations. In June of this year, we made an extensive search and found 251 results, 9 of which were eligible for our study. We used the Cochrane collaboration tool to assess our risk of bias, and that was done by myself and one of the other authors. And we used the GRADE tool and the Cochrane backgroup tool to look at the certainty of evidence for quantitative and qualitative pooling. For our 9 studies, 8 of these studies looked at the active substance versus control for primary tendon repair, and 1 study looked at sodium hyaluronate versus control for adhesiolysis after the primary operation. So the 8 that looked at the administration of the adjunct during the operation, we found 3 papers looking at sodium hyaluronate, 3 looking at ADCON-TN, and 1 each for PXL01 and mannose 6-phosphate. Our results will be centralized around sodium hyaluronate and ADCON-TN, as they have a greater number of papers. So if we look at the total active movement in the sodium hyaluronate group, we find that there was a midterm benefit that was almost statistically significant, but with a low certainty of evidence, with a p-value of 0.05 for these 3 papers. If we remove the top paper, which looked at single injection, and look at the bottom papers, which looked at repeated injection over time with a catheter that was placed in the flexure sheath, this then showed that the repeated administrations were statistically and clinically significant with a p of 0.01. Looking at ADCON-TN, there was no short-term midterm benefit, also with a low certainty of evidence, with a p-value of 0.89. And PXL01 and mannose 6-phosphate showed no significant mid to long and short to midterm benefit, respectively, with limited certainty of evidence. So the conclusions that we can draw from what we've looked at is that repeated administration of sodium hyaluronate appears effective in reducing postoperative adhesions at midterm follow-up. However, there are limitations which are obvious in this study, in that there are a low number of randomized controlled trials that are out there in the current literature, and these results that we have found are based on a low certainty of evidence from our grading. Our recommendations from this study are that large, well-designed randomized controlled trials are needed to guide clinical practice with more confidence. Thank you very much. These are references here.
Thank you so much for that talk. Robo's definitely going to like that last slide. In terms of question, are you still here? Can you still hear me? Because you've frozen on the screen. Elizabeth, can you hear me? Well, she might have disconnected at a perfect time. That was the last presentation, so we'll probably wrap up at this stage then. I would like to thank everyone who presented today. There was over. Oh, can you hear us?
I can hear you. Can you hear me?
We can hear you now. Right.
Yep.
Robert, do you have one question you want to ask? And then we can wrap up.
Okay. Shall I just say that's a pretty good presentation, Elspeth. Well done, especially being at work as well. It's always a bit stressful when you're trying to manage multiple things. I thought it was very well designed. You had a very clear question, the PICO format, really, really good, and you had outcomes that matched up to the questions you asked. You got a very specific answer because of that.
Thank you.
You did very, very good. So I guess the question is usually now what would you? I know you gave a general kind of point to what might be next. One question I would ask about methodology is that how did you manage the team? How did you lead the team in this study, or were you one of the team in the systematic review?
I was one of the team. This is my entry into research, if you like. I've noted it as a area I need to work on, and one of my consultants teamed me up with a registrar who's very prolific of producing systematic reviews. So this is really where I learned the methodology from somebody who does it regularly. So this
which bit of it were you specifically involved with? And I think it's a very good way to do it, to get into research with someone else. I think that's great. Which bit did you do you think? Were you involved with the searches?
I was involved in the searches. Reading of the Cochrane collaboration tool, looking at certainty of evidence, and I learned a lot through that, because I felt that at times I was quite easy on the studies and I was told to be harsher, and there was points that I learned there. I then wrote the manuscript myself, so that was also a big learning curve for me on how to write scientifically and how to make sure I'm not missing out any other studies, that when we try and submit this, somebody's going to say, well, you missed out this very important study or whatever. So the thoroughness there as well.
Okay, and so what did you do if there was disagreement when you were doing your searches? How did you resolve disagreements during the systematic review?
So we also had two consultants, one who had more of an interest in research and one who is also a hand surgeon.
Okay.
They also looked at our grading that we'd done to check that it was viable and answered any of our disagreements.
Okay, well, that's an excellent way to do it, having an independent educator. That's excellent. So my final question, because we do need to wrap up, is where would you go from this? You've got some findings. What's the next step when you move on from the systematic review?
So I guess we've only commented on what's out there. I think that this study shows that there's a paucity of evidence, but that these are adjuncts that don't seem to show any real adverse effects and only really could show benefit. The problem is that we're in not
Lost again.
I lost it.
Anyway, very well done. Very well done. Excellent study design and well presented.
She's disconnected completely anyway. So we'll wrap up. Thank you so much again for everyone who's presented. I think hopefully not only you've gained something for your CVs, but you've gained something for your education in terms of improving how we do research in plastics for our futures. I certainly learned a lot today. Roba, thank you so much for taking time out for on a Sunday. And you asked some really good questions there, and I think I've learned a lot from your questioning as well. So thank you for that.
Thank you for inviting me. They were excellent. All of them were very good presentations.
Perfect. And finally, I just want to thank the ABS and Mammoth Fold as well. Thank you for the sponsoring it, and I will post a link to the site for people to take a look as well into the chat. We will have the prize winners ready for the about 3 o'clock session, and the next session starts at 2 o'clock on the